Hello everyone, welcome to our YouTube channel. From this video onwards, we are starting the discussion on a new topic, the thyroid disorders. This is the first video of the thyroid disorders, so we will discuss about the goiter. We will see the definition of the goiter, causes, clinical presentation and evaluation. The definition simply is the enlargement of the thyroid gland. So in this picture you can see the normal thyroid gland, and in the left lower corner you can see the thyroid gland with a nodule. So it is also a form of goiter. And on the right lower corner you can see the enlarged thyroid gland with many nodules. So it is a multinodular goiter. So let's see what are the causes for goiter. There are many causes for goiter, but I will mention only few causes here. Iron deficiency is the most common cause for goiter worldwide, and also multinodular goiter, chronic autoimmune thyroiditis, Hashimoto's thyroiditis, Graves' disease, thyroid neoplasms. These are the causes of goiter. Regarding the clinical presentation, when a person presents with goiter, usually the patient is having an anterior neck swelling. Then we take a history from the patient. In the history, what are the things we have to ask? I have mentioned only few things here, but when we go to a long case discussion, you should organize a complete set of questions to ask from these patients. So we can ask the thyroid status, the clinical features suggestive of hyperthyroidism or hypothyroidism, then obstructive symptoms. What are the reasons for obstruction in goiter? Obstruction means the obstruction of the airway and sometimes the esophagus. Usually this compresses the trachea. So the obstructive symptoms occurs due to progression compression of the trachea, and the esophageal compression only occurs if the goiter is very large, retrosternal extension. And also the obstruction may occur due to sudden enlargement due to hemorrhage into a nodule. And in this case, the patient presents with pain. So if a person with goiter presents with acute onset of pain, then highly likely to have hemorrhage into a nodule. So the common obstructive symptoms are dyspnea, cough, wheezing, but rarely can get dysphagia. And we may ask something suggestive of malignancy, like recent rapid enlargement, hoarseness of voice. So hoarseness of voice occur due to vocal cord paralysis, so compression over the vocal cords. It may occur due to invasion of the recurrent laryngeal nerve and also with a large goiter. So if a patient is having hoarseness of voice, then we may think of the possibility of malignancy. And also we have to ask about the family history of thyroid cancer or any thyroid neoplasm, and also the history of head and neck irradiation. This is not just taking a neck x-ray or something. It is the irradiation therapy or either nuclear fallout may increase the risk of thyroid cancer. And also in the history we can ask about the medication history. So those are the things we can ask in the history of these patients. And in physical examination, so the patient is having an anterior neck swelling. There's a set of steps we have to do in these patients. In a previous video, we have demonstrated how to examine the thyroid gland. So you can watch that video and refresh your knowledge. Here I will briefly mention what we are looking for in the examination, that is the size of the thyroid gland, presence of firm or dominant nodules, and the presence of cervical adenopathy. So the detailed thyroid examination you can watch in the previous video. And there are WHO grades of goiter. WHO grade 0 means no palpable or visible goiter. Grade 1, palpable goiter but not visible when the neck is in the normal position. Grade 2 is visible neck swelling. So like that we can grade the goiter according to WHO gradings. Then in the evaluation, what are the investigations we can do? Initially we can do thyroid function tests, that is initially we do TSH. If the TSH is high, the patient is hypothyroid. If the TSH is low, the patient is hyperthyroid. After that we can, if we need, we can do free T4 or free T3 levels. Then we can do thyroid ultrasound scan to characterize the morphology of the thyroid gland, whether it is diffuse enlargement, nodular enlargement, solitary nodule, like that. And also sometimes we can do NCCT or MRI in cases where there are obstructive features and also in substernal goiter. So in those instances there is place for this imaging as well. And FNAC is very important for these patients. Usually we don't do true cut biopsy for thyroid gland because it is very vascular gland, so high risk of bleeding is there. So we do FNAC. The FNAC is done if there is rapid growth, pain or tenderness, and also if there is unusual firmness in one region of the goiter, and also sonographically if we detect any suspicious nodules, then we do FNAC for those patients. And also there are some other investigations which we can do. One is antithyroid peroxidase antibodies. It is a mark of autoimmune thyroid disease. So if we suspect autoimmune thyroid disease, we can do anti-TPO antibodies. And also thyroglobulin levels. It is a tumor marker for differentiated thyroid cancer. So if we suspect thyroid cancer, then we can do thyroglobulin levels in those patients. So that is briefly about the causes, definition, clinical presentation and the investigations we can do for a patient with goiter. So we will look at a few questions. This is a multiple choice question. A 50-year-old lady with WHO grade 2 multinodular goiter come to the clinic. What is or are the investigations which would support the diagnosis? So this patient is a 50-year-old female patient and having WHO grade 2 multinodular goiter, which means she is having visible and palpable goiter. It is a multinodular goiter. So what are the investigations which would support the diagnosis? Obviously we do TSH levels in these patients to assess the thyroid status. And also we can do ultrasound scan of the neck to see the morphology and to confirm the multinodular goiter. And in the other answers it is mentioned thyroglobulin levels, which we do for thyroid cancer. Multinodular goiter, the risk of thyroid cancer is very low, but it is not zero. There are some possibilities there. So we cannot exclude thyroglobulin levels in these answers. So it is no harm doing thyroglobulin levels in these patients. So we can do thyroglobulin levels. So A is true. Antithyroid peroxidase antibodies should be the answer. So it is not very indicated here because we don't suspect autoimmune thyroiditis in this patient. TSH of course we do, and ultrasound scan of the neck we can do. X-ray of the neck is not really indicated here. So the correct answers are TSH, ultrasound scan of the neck, and thyroglobulin levels also you can take as true. Other question. A woman who has had the multinodular goiter for 2 years duration presented with sudden onset acute pain in the neck. What is the most likely cause? So if a patient with multinodular goiter presents with sudden onset acute pain, then the commonest reason is hemorrhage into a nodule. So the answer is hemorrhage into a nodule. Like that, questions may be asked from you in the exam. So in the future videos we will further discuss about the thyroid diseases.